tuned for the following special, Life Choices, The Acts of Caring.
And now here is my secret, a very simple secret. It is only with the heart that one can see rightly. What is essential is invisible to the eye.
There's a reward that you get in working with people and knowing that you've maybe helped them through some experience.
I think a lot of people don't really know what nursing is about.
I think we do a lot of the part of the healing.
The families that we've cared for are so grateful and so thankful for the care that they receive.
Sure, I think about quitting sometimes, but probably sometimes 100 times a day, but I always seem to come back.
It's rewarding.
Hello, and welcome to this Life Choices special presentation. I'm Mary Chapman, the host of Life Choices, and also the president of this hospital called Riverside Methodist. Occasionally at my work here at Riverside, I put on this blue scrub suit so that I get the chance to work alongside a remarkable group of people called nurses. Did you realize that inside an 8-hour shift, most nurses do more to help others than some people do in an entire lifetime? And yet the sad fact is that most of us simply do not understand the vital work that nurses do. We took cameras where cameras usually don't go so that I could share with you this unique and unprecedented look inside the world of nursing. It's dawn on the campus of Riverside Methodist Hospitals in Columbus. 5,000 people work here. 1,000 of them are called nurses. Buildings, machines, and medicine don't mean anything without their special acts of caring. 7:05, Nurse Marianne Costa begins her shift.
Linda Teach in 1. She's a 27-year-old prime ep of Dr. Bill Copeland, Jr. She's here for an induction because of her elevated blood pressure. The moment of birth is not an ordinary experience. That actual instant right there when the couple first sees the baby, they finally know if it's a boy or a girl. The mom and the dad get all excited about the baby. For as many deliveries as you do, that it's unique, each one, because you've developed somewhat of a rapport with the couple. She's made some slow progress. Her husband, Tim, is in there with her. Tim's deaf, but he reads lips real well, and it doesn't seem to be a problem. So you ready to have a baby today?
Yeah.
Yeah. Okay, I'd like to ask you some questions before we get going here, if you don't mind. Did your doctor talk to you about an induction at all? Did he explain what that's all about?
Yes, he did.
Okay. They're in here for a once or twice in a lifetime, maybe they have 3 kids, if this will be their 3rd child. Once or twice in a lifetime experience is very special for them. They deserve a lot of attention. They deserve high-quality nursing care when they come in here. Slowly progress, and we'll have different monitors on you so that we can gauge accurately how fast your labor is progressing and how strong your contractions are.
I might ask you about the veins they're going to take out of my legs. Are they?
Nurse Renee Spielman talks with heart patient Sam Hammond before his surgery.
Right. They'll take the veins out. They'll start usually with your left leg, and they make an incision on the thigh and take out that part of the vein and see if that's good enough to use around your heart. They want to match the size of the ends to the arteries around your heart because they want to get the best vein they can to carry that rich oxygenated blood back to your heart. I try to treat my patients the way I would want to be treated in the same situation. I'm a very modest person, and I make very conscious effort to try to maintain some people's modesty, because in the hospital, that's the first thing that goes. And consideration, I mean, if they're having a bad day, I'm not going to push them real hard. Granted, I might need to get some things done. That arm I went low. No, this arm I went up on his face. That supports that chest incision. When we move you, you need to support that chest, because that bone's been cut. It's like a broken bone. Now you're going to blow out. I want you to blow out like you're blowing out candles and lean up. Great. Now I want you to take some deep breaths so I can listen to your lungs.
All of Nurse Lynn Davidson's patients have cancer.
How are you doing?
Pretty good this morning.
Good. Ready for your bed to be changed?
Ready for the new bed. Yep, that always feels good.
Good.
As an oncology nurse, myself as well as our team up here, we try to promote the quality of life that the patients have. We're involved with the patient and we're involved with the families. we really try to offer support to the families. So often you see the spouse just exhausted, and you know, just to say to them, hey, go home, take a shower, get a good night's sleep, we'll be here. They'll be okay. If anything changes, we'll call you in a flash.
Okay.
9 a.m., Lynn comes to see Christine Williamson, age 37. 19 months ago, Christy's husband died suddenly of a brain aneurysm.
So no blood today. And
3 months ago, Christy learned she had leukemia and may not have long to live.
That's good. Are you feeling as good as your counts sound?
Christy has a 15-year-old son.
I'm still having those headaches, and I still was concerned because my throat started to bother me last night.
Let me see in your mouth a minute. See ya? I don't see any white patches at all.
That's good.
Did you tell the doctors about how you were feeling?
Well, I sort of forgot this morning. I was.
You did?
Yeah.
How's about if I go ahead and get you on the fetal monitor here, and then I'll go through the questions. I'll do this first. See,
Sure.
This way we can keep an eye on Junior while I'm getting you admitted.
Okay.
By the way, is this a boy or a girl?
This will be Linda and Tim's first child.
No hunches?
No. Well, I don't know. Really, you'd be surprised by this.
Okay.
The fetal monitor tracks the baby's heart rate.
Normal range is 120, like I said, to 160. And your baby's right there in normal.
Now, you got a couple things running through your head right now. You have Mr. Hammond that you're taking care of, and I guess you have a patient in open heart recovery. Mr. Hickman, who's going to be coming over, and then you have Mr. Foster that you're taking care of on the other side of the hall.
Right.
How do you keep all these situations straight in your mind?
Practice, no.
Let's give us an update on your patients.
Well, my one lady in the birthing room here, she's came in for an induction of labor because she's a little overdue, and she's having a little bit of trouble with her blood pressure right now. So I've done a few things to try to see if it'll come down. I've changed her position, got her bladder emptied, and we're checked her reflexes and this type of thing. So I'll recheck her in a few minutes, see if her pressure's down, see how things are going.
How about Tina? How's Tina coming?
Tina's doing okay. I need to check her, see how far along. Baby's looking great. She's in a nice, regular, consistent labor pattern. Things are looking okay.
It's a first birth also for Tina Elliott and her husband, Tom.
Women handle labor differently. I think everybody's pain threshold is different, and everybody, you bring that into you when you're in labor, too. She's a very stoic person. She's very quiet in her pain. Hopefully she's not in too much pain now. Hope we've helped her out with that. But she's a quiet person. She prefers not to have a lot of intrusions. She's focusing very well on her husband and his coaching. They've worked obviously well together in practice there in Lamaze. He's very able to sense when she's tensing. You know her tense spots, huh? You've been practicing.
I've been afraid sometimes when it gets real fast-paced that I'm going to make a mistake. You know, and that's my biggest fear. I go home and sometimes I call back and, did I do this, or did I give this med, or, you know, and that's not uncommon. There's a lot of us that do that. We go home and call and say, did I do this, or, you know, because we're afraid of making a mistake, and that's my biggest fear.
So many people have said to me, oh, Lynn, you're so calm. And I know inside I'm just a jumbled mess, but I'm thankful that I appear that way. And I think as I've become more experienced with working with cancer patients and with working with patients in general, I do feel more calm because I'm not as afraid of the situation that will come along that I'm not ready to handle. I feel like, you know, I could probably handle most things that would come along.
See, it's 10 now, and you're scheduled for 11:30. My guess would be that they'd come around 11 to get you. And I'll give you your medication before you go. You have 2 shots that'll help you relax and pretty much, you know, probably go to sleep a little bit, and then the anesthesiologist will make you go to sleep the rest of the way.
Thanks for that. I don't know, Mr. Hammond, if it helps or not to know how many thousands of people have been through this procedure, and, but maybe it does.
Well, it helps some.
Yeah.
There's still an anxious feeling.
Sure, absolutely.
Naturally. And
if you have someone who's got real severe anxiety, how do you take care of them?
A lot of times we will call the surgeon and see if he would have a couple extra minutes to come over and talk to this person and reassure him, which a lot of times help. And we encourage the family. Sometimes we call them early in the morning and say, please come over early, and you know, at least the family's there to sit with them and they don't feel like they're alone.
Dr. Osborne, you're going to be going in to operate Mr. Hammond in about an hour, huh? Yes.
An hour and a half?
Yes, he came in last night, and he's had his angiogram already here as an outpatient, I believe, and so he's pretty well set up.
Now, you would expect, I guess, a little bit of anxiety, which he feels. He's fairly calm, but he's a little nervous, according to Renee.
Well, it's a big step. This is not something to be taken lightly, and it's certainly something that doesn't happen every day to an individual. And that's something I think it's important for us to always remember, because that we are exposed to it every day, but the patients and their families are usually only exposed to it once. Mr. Hammond is about to begin his journey through bypass surgery.
You can walk over with them so they go in surgery. All right?
How's it feel to send a patient down to surgery?
Oh, I feel pretty confident about Mr. Hammond.
I asked Christy how life looks to her now.
It's really funny I get that type of question, because in the last couple months, I see my life is going maybe a year. I've talked to my friends about it. It's something that I've dreamed over and over again about, being buried and being at a graveside. It's something that, you know, I've tried to block out of my mind. But right now, all I'm trying to do is take one day at a time. That's all I can do. And keep thinking that each day is going to be more and more rewarding to me.
We have had some patients that fight us every step of the way. They get this attitude that they just want to die and that it's not worth it. And it becomes very difficult to handle a patient like that. So we try to be extra positive and say, you know, yesterday you couldn't do this, and look at today, you're doing so much better.
Hi. Okay, ready for the IV?
I'm ready.
This looks like a lot, but it really isn't. We start the one IV and then we piggyback the Pitocin into it. Okay. Just talk to your doctor, and he ordered a bunch of lab work for you.
That's funny.
Mary Ann's training and experience allows her to perform hundreds of tasks effectively.
Electrolytes and coax times 3. PT, PTT, and platelets?
Yeah.
Okay.
We've had a chance to meet and watch Renee a little bit. You're the nurse manager down here. You're the one that's responsible for the actions of the nurses on this floor. Tell us about Renee.
Renee's been here about a year and a half. And I happened to get her from the float pool. She was floating up here a few times, and she just loved the unit, and I loved her. So I was really anxious to have her.
I enjoy this floor. I enjoy the surgical patients.
Why?
Because they're sick, you help them, they get better, they go home, and they're happy. They're like so thrilled to leave. It's a nice feeling to be able to let someone go home.
There is some kind of quality that she has, and the majority of the nurses on this unit have it too. It's almost hard to talk about her, hard to know what it is. But she can look at a patient and she can tell instantly what's wrong.
The patients that come to our floor, I would classify as potentially serious, because they all have the potential to have something happen to them, something life-threatening. Now, we have very good statistics here, and that doesn't happen that often, but we always keep a close eye out for it and try to catch it in the early stages so it doesn't develop into anything too serious.
You know, sometimes there's a lot of anger up here on the part of the nursing staff. You get angry when you don't have enough staff. You get angry when you can't save a patient's life. You get angry when you can't work as fast as you want to or as efficiently as you want to.
There are a lot of days where I've had a bad day and I go home and I'm tired and maybe cry or just emotionally exhausted. But for every one of those days, I bet I have 3 great days when I come home and I'm so excited because my patient did this, or so-and-so got to go home, or, you know, someone's doing better, or, you know, I get just as many as those days, even more good days than bad.
It's a fine line that we walk all the time. How do you stay detached,
Yes, right.
professional, without getting involved in each patient's lives and owning, you know, all of their problems and everything that happens to them, but still be sensitive and caring?
How long have you been the leader of this area?
4 years.
4 years.
I started as staff nurse and then was assistant head nurse, and then I've been the nurse manager for the last 4. I think we have a real good team here because of the fact that we're all here for the same reason. We're here for the patients and their families. It's horrible to work Christmas night at 11 o'clock by yourself when you'd rather be at home, but the fact that you chose the profession, you realized what it was when you were going into it, and the sacrifices that you would make, and why you're making those sacrifices, that it's not for the monetary gain especially, but that the patients are here and that they need you. And the only way that we can achieve what we need to achieve in the end is by working together, and they do a real good job of it.
I must say we have an extremely knowledgeable and supportive nurse manager. And I think that she makes all the difference, because if you had to work on an oncology floor where there was no unity in the staff, where your nurse manager was not really there for you and keeping the floor organized and maintaining the high standard, I think it would be a lot more difficult to function.
My worst days are when we're crazy busy and you're running and you are unable to devote any time to that rapport with the patient, and you feel they are not getting a fair shake. You know, you're educated to give a certain standard of care, quality of care, and it's extremely frustrating to have your arms tied to whatever circumstances, whether it be short staffing, just an onslaught of unexpected patients, a high acuity level of the patients that you have there, unexpected higher acuity, for whatever the reason, to be forced not to give them the attention that they really need for high quality care is very frustrating. It's a very busy unit. You know that. Yeah. And sometimes there's some trading off of patients that can get to be a little disheartening at times, but you can't be two places at once. And patients that are that close to delivery need one-on-one nursing care. And when you're able to provide that, that's fantastic, and that's the way it's got to be.
Let's take Marianne Costa and the other nurses in labor and delivery. They have this very intense experience with the patient right up to the point of delivery, and then the patient is turned over to someone else. I wonder if there's a feeling of loss for those nurses, because they have this high intense experience and then it changes so quickly.
I would agree with you that there is probably a feeling of separation associated with one nurse transferring her client to the care of another nurse. And I think a lot of that has to stem from the amount of time that she has spent in intensive interaction with the family or with the mother during the birth process. The client who is laboring seeks out and pulls into her birth experience not only the husband, but the care provider, be that a nurse or a physician.
You feel pulled, while you're in taking care of the LAs, are you wondering across the hall if things are okay?
Not really. I mean, I've there's a lot of confidence in the other nurses that are working there, and everybody pitches in.
My name's Judy. I'm just going to be relieving
RN Judy Bowles is a 20-year veteran of nursing.
Okay. How's it going?
Fine, you're coming right along.
What I'd say. My word. You still feeling these?
Yes.
Okay, they didn't dose your epidural yet, did they?
No.
They just put it in. Okay.
Okay, so you got the Benadryl and the Tylenol that you took orally.
All right.
And then the hydrocortisone is in the bag with the amphotericin.
That's the stuff I used to get with a shot, right?
Mm-hmm. And all of that will keep you from getting, having a reaction.
I hope so.
Yeah. Me too.
Very good.
What are you listening for then?
Listening, you can hear lung sounds, and if you just have clear lungs, you just hear the air exchange. But I hear what's little crackles, and that's water in the lungs. And
So would you hear some of
rales.
that with him?
That's pretty normal. We hear that with, basically all of our patients.
And
that's just because of the fluid.
The fluid is...
Okay, they have you work on this over there?
Yeah.
We're gonna just do a couple since moving's such a big job, but I want to see how you're doing on it. Use that with your right hand? Okay.
Oh, either hand, I don't care.
Okay. This is the one you suck on like a big straw. Oh my goodness. Great. Let it out. That's the best another one. Oh yeah, at least 5. That's the best I've ever seen anyone do.
Once they dose your epidural, you'll be real nice and numb.
except for maybe one part, and you should be able to feel pressure down real low in your bottom. And that's something that we choose to leave there. We don't want to get rid of that. Okay. So that once you're fully dilated and it's time to push, you still have that pressure sensation that makes you want to push. Okay. And that's real beneficial. Okay. So you'll get real nice and numb to pain, thank goodness. Yeah. But you may still have a pressure feeling, and that's what we want.
There are two types of people that are attracted to nursing. There are the type of people that really want to help people. I would say all people that are attracted to nursing want to help people. But some are stronger in that, that's really what they want to be there for, and they do the technical things, and they're proficient at the technical aspects of it. But they don't thrive on that. They thrive on the actual patient care. I think that the other type really thrives on the technical aspect, and there's nothing wrong with that at all, because they still give good bedside care, but they really enjoy learning about the human body, about all these new procedures that can be done to enhance the health of a person. And so I think that a lot of people that are interested in the technicalities also are interested and attracted to nursing.
Push them through, keep going, and let
Across
it go.
the hall from the
Take it
teachers,
again, right away. In,
Tina and Tom Elliott move closer to the moment of birth,
push them through.
but lots of work still remains.
Okay. You got to do it again. Do it again. No. Come on. In. Push. Use your contraction. Come on, Tina. Push to 5. 1, 2, 3, 4, 5. Okay. It's okay. You're doing okay. Yeah, it's okay. Yeah. You're feeling the pressure, hon. Pressure the baby down a little bit lower. Yeah, now take it in and hold it and bear down with it. Okay.
6, 7, 1, 2, 3, 4, 5, 6, 7. Okay. Oh. One more time. Breathe in. Okay.
Come on, push him out. Come on. Okay. Good. Good job. Do you have any more? Do it again. Do it again if you can. Come on, real deep. Bend your elbows back. Come on, bend your elbows back and push. Push. Yeah. Feel the difference? That's the pressure. Push.
Marianne's voice is a steady guide.
Very good. I'm seeing the baby's head poking through a little bit.
How is Mr. Hickman likely to be feeling when he comes in the door here?
I think there's going to be a little bit of relief that he's finally made it back here. Most of our patients, when they come over, they're tired. And just from getting from one bed to the other, usually a lot of pain, just because they have to move around. So we just kind of let them settle down a little bit. And as soon as we get them checked in, we let them see their families.
You can control a lot of his experience. I mean, you can control to a degree with medication how much pain he feels, and you can be monitoring his vital signs, right? So that he's probably pretty safe once he gets into this bed. Is that right?
Oh, we try to maintain a safe environment for him and try to take a lot of different things into consideration. Of course, the physical stress that he's been under, but emotionally too. The family just wants to talk a lot and everything, and it's difficult for them to understand that he would just like to lay there and sleep.
Take it again. Come on, Tina.
Push.
Yeah. Get your elbows bent back a bit. Great.
One more time.
Take it again.
Push.
Bear down.
Push.
Yeah. Okay. Let it go. Do you have some more left? Does it still hurt? Yeah. Okay. Not going to be long. I saw this much. Big breath in and out. We're going to get you up in the stirrups here in just a minute. Time to have a baby, okay? As is normally the case with a primipara first-time mom, that she was afraid to start pushing. It's painful, and she wasn't clear as to how long this whole process would go on. And couples at that point need a lot of reassurance that this is going to end, and that point where they are finally able to start pushing is almost a turning point for them, because the end is in sight. They've got it to 10 centimeters now. all they have to do is push the baby out. Unfortunately, they don't usually realize that it takes more than just a few pushes for a first-timer to get the baby out.
Riverside Emergency.
In an emergency, Riverside.
I got operated on one day and I went home that evening. I come back the next morning. I had my patch taken off, had my eye checked, and I had 20/50 vision.
Cataracts are the #1 cause of poor vision among adults. But with innovative techniques, thick glasses and hours of painful surgery are a thing of the past. The miracle of restored sight on the next Life Choices.
When I run a fever or when I'm getting ready to have a blood transfusion, I always think something's going wrong with my body. I feel like there's a possibility that I could be dying. It's just a fear that I have about me, about whenever I have to have blood, or like that night of last week when I started hemorrhaging. It sort of frightened me. I started getting my things together and knew that, you know, something was going on with my body. You know, was I going to be able to make it home this next time?
When you go into a room, do you see a patient with leukemia, or do you see a person?
I would say when I walk into a room, I usually see a person. I really do. Initially, I may be functioning on knowing what their diagnosis is, but sometimes I find I have to go back to my notes that I keep with me and remind myself of what their exact diagnosis is, because it's kind of slipped my mind, you know, as far as the exact type of cancer that this patient has.
Most of our patients put pretty high expectations on themselves. They think they're all Superman and going to fly through the surgery and jump out of bed and run around, and they don't realize that that's just not the case. I mean, I think if they knew exactly what happened to them, it would be a little more, you know, realistic for them to think that I'm not going to jump out of bed, but we only tell them a little bit not to scare them, but just so that they're informed, so they don't think it's really as difficult or serious of an operation as it really is.
It was just, you know, I mean, there are miracles.
Even in the finest medical centers like Riverside, it's impossible to succeed when some things are outside human control.
I can remember one patient who, he was a 40-year-old gentleman who had a really bad heart attack, had surgery. When he came over here, he did real well with his surgery, but when he came over here, he had a stroke. And here we are with a 40-year-old man with a stroke, and he was totally paralyzed on one side of his body, aphasic, which means he could not speak. And we were devastated. It's hard enough when it's somebody who's older, but when it's somebody who's young, you know, we take that very personally. It's very hard for us. So we worked with him, you know, just like crazy, doing all sorts of physical therapy. People brought him in, you know, racquetball so that he could work on strength, and it took him a while. But I just got a letter from him last week, and everybody talks about him and you know, mentions his name and says, gee, I wonder how he's doing. And every single person on this unit helped him to get well.
You know, I can think of one person, and I'll probably remember him the rest of my life. It was over Thanksgiving weekend, and he was so sick. Oh, this poor guy, he was so sick. And I worked 12 hours on Saturday and 12 hours on Sunday. And another nurse came in, you know, for the other 12 hours, and the two of us just took care of him. We tried so hard and worked and worked and worked, and he really started doing better Monday, and Tuesday he died. And it was just like so frustrating. I thought all my work had just gone to waste. But then after I settled down and I think about it, then I guess he did live 2 days longer, maybe because of my hard work and was able to see his family and say some things to them that needed to be said.
Most of the time the patient comes in, things go well, but have you ever lost a mother in all your years of nursing?
Yes. Twice.
Twice. And that's 11 years at Riverside. You've been 19, 20 years in nursing
Right.
altogether.
Right.
2 times. Huh?
2 times. That's too many.
Yeah. Do you want to talk about either one of those?
One was really devastating. The patient herself had been told by her gynecologist and by her pediatrician for years that she should never conceive a pregnancy because she had some anomaly in some of the blood vessels in her brain. They knew this from the time she was a young child. She was 24 years old, and she chose to risk a pregnancy. And she made it to full term.
24?
Yeah. She made it to full term, doing beautifully, and her husband was going off to work one morning and thought he heard her fall upstairs. And indeed, when he got up to the bedroom, she was on the floor unconscious. The patient was unconscious at the time she was brought in, and her EEG was flat, and we sectioned her, and that was it. It was over. He had a baby and no wife. And really, the most important thing you can do at that point is let him talk. Just be there and listen and let him talk. You can't force anyone to talk, but when they're ready, that's the best thing you can do. Just let them and listen.
When you begin to determine that the patient isn't going to make it, as happens with oncology patients, Dr. Gutterman, you know this patient isn't going to pull through. Do you begin to change the instructions or the comments? Do you say to Lynn, this patient's not going to live?
Oh, yeah, it's important that they know, and we do that to talk and discuss with everyone, the whole team, to know where we're at in terms of care, what the level of care will be needed, family support that's going to be required as the patient is going through the dying process. So we do have to be in touch with each other on this so that we'll be able to know when to back off, not to be as intense in certain areas of treatment, yet be supportive for the patient as they go through this process. Yeah.
One of the challenges for a nurse, and I think for any healthcare professional, is deciding for themselves how to maintain a certain distance, maintain a professionalism, and allow yourself to become involved emotionally with the patient. Right? And you need to look at every circumstance or every particular patient, every situation, and engage that. Certainly, a patient that I may have who is laboring with a baby that has died, and they know that. We call it a fetal demise. Invariably, there's an emotional attachment that develops there. I mean, I can't relate to that experience, but I mean, as a woman, and I mean, it's just a sad experience. Any human being could relate to what these people must be going through, or empathize with them. But you still need to function. You still need to do your job, and if you need to withdraw a little bit, that has to be done. But you balance it out. I guess it's more of a balancing act to be able to empathize with the patient and do your job as well.
I know that Mrs. Hammond was very anxious this morning, and the waiting being the second case in that OR, it's tough because they tell you 11:30 and they didn't come until about 12, and that extra half hour you count on a certain time. It really causes a lot of stress, but I stopped in and saw her in the waiting room after Dr. Osborne talked to her, and she's a lot relieved, and she's glad that things went well, and as soon as they get him situated, she ought to be able to go in and see him a little bit.
Just hurts. Ready? Push. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. One more time.
Not the next one, the one after that, and then
Next one.
7, 8, 9, 10.
Right here, and I
feel like pushing.
Well, I want you to push a glove
Now?
over to me. Yes, ma'am. You got a
1,
contraction. Bring her down.
2, 3, 4, 5,
It's really
6,
coming down.
7, 8, 9, 10, 11. Come on, over
Really
here.
down.
Push. 1, 2, 3, 4,
There you
5,
go.
6, 7, 8, 9, 10. One more time.
Got one left?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Listen, you almost had it that time. Now just relax for a second. Give yourself a little chance to recover. Well, wait till you have a contraction now. Even though it's right down here and it does give you that.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Now bring it on out. Here we go.
This time 1, 2, 3, 4, 5, 6, 7, 8. Oh, I see his head.
We got a baby. Now relax, son. Relax a little bit. Boy, oh boy. Either a boy or a girl.
Oh, he's cute.
Yep. Just pant a little bit, because I like to blow the baby out for you on that.
Here, here. Here.
Hi, Mom.
It's 2:58 p.m. Baby Thomas Elliott has arrived.
Congratulations. Great.
Marianne proudly holds up baby Thomas, age 1 minute.
I was grateful that she didn't have a long pushing time because she had been so anxious and nervous about it. And she did very, very well. And fortunately, she didn't push very long. And baby was fine. I could see right after delivery time, and it was a relief. Like everything, as soon as you hear the baby cry, it's like, okay, relax, everything's going okay, and then just proceed with what you need to do. And it's nice to see the mom and the dad get all excited and about the baby.
Where some nurses have actively sought to interview the client in the postpartum period. It's all right, I'm going to let you care for her now that she's going to be a postpartum patient, but I'm going to come by and visit her. I'm going to ask her about her labor experience and have her give me some feedback on things that I could have done a little differently for her, or things that she would want done a little differently when she comes back to our facility to have her second or third baby.
I know she spent a lot of time, up until the end, as a matter of fact, in the 8 hours you were here, you spent a lot of time with Mrs. Elliott and with Mr. Elliott, and now with their baby Thomas. And the doctor sort of comes in at the end, so it's you, you and them.
Yeah, I can't tell you how many times I've been told, it's usually by the husbands or by the wives, they say, geez, you know, you've been here all day long. Doesn't it make you kind of mad? The doctor walks in and delivers the baby, and then he's gone, but you've been here all day, and he gets all this credit. And I used to say, no, well, you know, he's got the full responsibility, and he's been, you know, handling your prenatal care for X amount of months, and this is his job. And now I say, yeah, it makes me a little mad. I've done most of the work here. But again, hey, it's, you know, it's his job to catch the babies. It's my job to help the women during their labor. But it is a little unsettling, to be honest with you.
You know, 15 or 20 years ago, the nurses all stood up when the doctor walked into the nurses' station.
I don't really think it's called for. The nurses still show a lot of respect for the physicians as long as you show respect for them and the job that they're doing.
So it's a more mutual kind of a relationship.
Right, and it should be that way.
The nursing profession has evolved, and that the women, many of the women in nursing are no longer content to act as a subservient role, and those days pretty much are long gone. And you'll find very few nurses who are willing to do their job only by what is told to them, and you exercise very little personal judgment, that type of thinking in nursing is finished. That's something of the past.
The times that I have felt the best, and I'm sure I speak for a lot of nurses, is when you go in and you picked up something. This is kind of a challenge. You picked up something that nobody else picked up, and you were right. And then, you know, somebody said, "Oh yeah, that's right," and then you treated the patient, and they started to turn around and do better. It's kind of like, ooh, you know, that's really a neat feeling. There's just nothing else like it.
But it's really nice if you find a problem, and if you're still there when the physician comes in and decides how he's going to treat that problem, you're the nurse that's able to give that particular treatment, and then the patient responds. It's a really neat feeling.
Because I'm with the patient 8 hours a day, and the doctor might be in there just a couple minutes. You know, granted, he might know more information about it for me, but he relies on me to give him accurate information about what I think is going on and what is documented through vital signs, what the monitor says, and other tools.
I really feel that the doctors give us a lot of latitude. I think that, you know, their expectation is that we are going to pick up things on these patients and you know, in the simpler things, just to go ahead and treat, and then call them and let them know what's going on and what we've done so far. And that's pretty much the way the unit is run, is that, you know, we are the decision makers a lot of times, and then let them know what we're doing, and then they add on to that, you know, treatment.
Well, I think that sometimes they would like certain things to be done on patients, and as a physician, our judgment may differ. And again, that's only normal, that's human. And we just all have to gain understanding that there are certain ways things are going to be done. There will be differences of opinion, but we're all working together for the patient's benefit.
Nurses who are in nursing and have been for as long as I have been are the ones who really love it. We're the ones who are here for the patients, and we take all the grief from all directions, and we still love it. And yet, on the other hand, we would be the ones who would say to someone else, "You're crazy if you're doing this, you really are."
Or the nursing profession is having trouble attracting people. Probably, one, they don't feel that the pay is what they would want or could receive from some other field. Also, the history of what nursing is about. I think a lot of people don't really know what nursing is about, and they just envision bedpans and, you know, cleaning up things that most people don't want to clean up. And that's really not the way it is. Yes, there is that aspect of it, but I think that a lot of times people really don't realize what nursing is about. And because of the lack of staff across the country, that does make it hard on a person physically, emotionally. It's extremely stressful to work in an understaffed situation. And I think that a lot of people may be aware of that and choose not to put themselves in that.
I think that the public needs to be aware of some of the problems facing nurses. I think that people who may be interested in going into the nursing profession need to come in with their eyes open. And it's not all rosy. It's very difficult work. It's very rewarding work. But it's difficult. It certainly has its share of problems right now. How you feeling?
Great.
Yeah, it's looking great. You're having some heavy-duty contractions here.
Uh-huh.
But you don't feel them, right?
Right.
You've got the epidural in?
Mary Ann is nearing the end of her
Wonderful
shift
anesthesia.
and will miss Linda's delivery.
Well, you've done real well today. It's time for me to be leaving. There'll be another nurse, Kathy, coming in just a few minutes to take over.
Okay.
Okay, so just wanted to wish you good luck and congratulations in advance, okay?
Thanks so much,
All right,
Mary Ann.
I'll see you. Bye-bye. Bye, Tim. Congratulations.
Is that the first food you've had today?
Yeah, actually.
So it's 10 minutes to 4 and you're finally getting something to eat.
Yeah, well, that's true.
I think we've gotten away from sitting at the bedside and listening to the patient's needs. You know, everything is so technical these days, and it's important to listen to the patient. What is important to them? What are their issues? What are their needs? Rather than what we think or perceive their needs are.
I had a patient who was diagnosed with leukemia in September of 1987, and he probably had almost every complication in the book. He had pneumonia and both lungs collapsed. He was on a ventilator and transferred to ICU. He made it through that, came back to our floor, then had a drug reaction to Compazine and had his neck stuck over like this, and had lost all of his hair. He had 3 young children, a beautiful wife, very prospering man in his field of work, and anyway, but he made it through, and it just looked like he really might not, and then did terrifically, and we didn't see him for months.
It's just a feeling that we get about patients that come over and they think everything is wonderful. Those are always the ones that we tend to watch a little more carefully because for some unknown reasons, a lot of times that they have problems.
And he went into renal failure, wound up having to go through dialysis. They had to cancel the bone marrow transplant, and a few weeks later he died in dialysis. And to me, I just could not believe it. I just couldn't accept that he was in total remission from his leukemia and had died from a complication. And I just found that so hard to swallow, and I think the whole floor was hit hard by it.
I always think, is there something I could have done? Is there something I missed? Could I have caught this sooner? There's a lot of self-doubt that goes on when we lose a patient. Because we're supposed to be here to save lives, and it's a real backstabber when one dies.
I did go to the memorial service. I felt that would help to bring closure and see his family again, and be able to just to see them and just to hug them and just to let them know that I was so sad that it had happened that way.
It's still hard. Today.
Yeah.
Do you still see his family?
I haven't. It's too close to the time. I think for them, they're still trying to recover.
For Riverside emergency nurse Sue Finnerfrock, it takes dedication. For Kelly, it takes skill. For Sue, it takes skill. For Kelly, it takes effort. For Sue, it takes effort. Riverside salutes this spirit in all its nurses. The spirit that reminds us to reach for the champion that lives within us all.
That a girl.
5:40 p.m. Fellow nurse Kathy Kelly is now taking care of Linda.
Keep pushing, you're doing great.
Nice, keep coming.
Keep it coming.
Okay, you get one more push.
Go again.
Boy, you are just some fantastic
Wonderful.
pusher, let me tell you.
Wonderful.
Okay, one
Come on,
last
go
push,
again.
Linda.
Gonna have it before.
Nice going, Mom.
Let's see what it is.
This is a big
baby. Girl.
Girl.
It's a girl. It's a Rebecca.
Hi, Rebecca.
Right, Rebecca? Everything okay? Looks fine.
Yeah.
She's opening her
Each patient is their own particular entity. They are all very different, and each patient deserves 100% of your care and mind and the very best that you can give to them. And it doesn't really matter what their needs are. You should do your best to meet each one of those needs.
All right, young lady. Rebecca?
Rebecca.
Oh, that's beautiful.
Rebecca.
Frankly, out of college, I had no desire to be in oncology. I'd worked there as a student, and I was very unimpressed. But then when I came to this hospital and worked in the float pool, and was on the oncology unit and just saw the quality of nursing that was there, I just felt like I really wanted to be a part of it.
We have to be very sympathetic and very caring people. And it always bothered me when I'd see someone treat a patient roughly or not speak nicely to them. Everyone would have a bad day and you might slip and say something you really didn't mean. But the people that do it over and over again, they don't make good nurses because they don't care about their patients. They're not willing to open up their heart and treat that person as if they were someone that they knew and were close to.
The bottom line for me in nursing certainly isn't the paycheck, because nobody's going to be a millionaire or millionaires being a nurse, but it's the bottom line is the job satisfaction, and you get that from the providing patient care, high quality care. I mean, that's great. That's what nursing is all about.
What is essential is invisible to the eye, the little prince repeated, so that he could be sure to remember.
Something for everyone, and I have something for you. Come into my life now and stay a while, and I will try to give you something beautiful to light your life, to keep you strong. Something beautiful to light your life, to keep you strong when you are alone. Something beautiful to light your life, to keep you strong when you are alone.
When we were kids, a lot of us said that when we grew up, we'd like to help others. Actually, nurses live a life like that. During one 8-hour shift, most nurses do more to help others than some people do in their whole lifetime. If you think you'd like to be a Riverside nurse, to join our team, please call 261-5165. Or if you're out of town, call area code 614-261-5165. You'll have a chance to live a life dedicated to helping others.